Thank you, Louisa. I'm Steve Roach. I'm the chief of the neuroscience program at Dell Children's, and I'd like to welcome everyone. We have a small but dedicated group here in the audience, but there's another, I think we figured maybe 75 people online. And so I think the award for the most distant registrant is Barcelona. And we also have welcome colleagues from, let's see, not a complete list, but Cincinnati, a couple from Michigan, Tulsa, Indianapolis, and Wisconsin. So anyway, welcome to everyone. First, I'd like to thank a few important people who have put all this together. So Dr. Louisa Keith, you just heard from, and Dr. Dan Friedman are the co-organizers of this. They put a lot of work into it, and so thank you. Also, hats off to Jessica Valverde, who's trusty admin for everything we do, who's important in this. The UT Health Austin Pediatric Neuroscience Program was founded 4 years ago, and is a multidisciplinary program with neurology, pediatric neurosurgery, pediatric rehab, pediatric neuro-ophthalmology, and pediatric neuropsychology. We've managed to put together a great team of national, international experts, many of them, in topics like pediatric headache, epilepsy, stroke, neuroimmunology, rehab, neurosurgery, autism, movement disorders. And so this is, the program has grown rapidly, and this is the fourth symposium that we've done. And in our view, this is a chance to introduce our new faculty members, but we also look at it as an opportunity to give back to the community. And so this is, today's symposium is for all of you guys who work so hard every day to keep our children well. And so hopefully this is neuroscience, basically neuroscience that primary care needs to know about is the format. So without further ado, I'm going to introduce our keynote speaker for the day. Jane Edmond is professor and chair of the ophthalmology department at Dell Medical School at the University of Texas. She also happens to be a pediatric neuro-ophthalmologist, not a lot of those around, a very good one, I might add. And because of that, her practice is embedded in our practice, so we're proud to claim her as part of the neuroscience program. In addition to a storied career and an international reputation, I'm not going to eat into your time too much, Jane, but she's also the president-elect of the American Academy of Ophthalmology, which starts January, I think, or?
Presidency begins in January.
Okay, and so we're very proud of that. So anyway, Jane's going to talk to us today about neuro-ophthalmological problems presenting to general pediatricians. So, Jane?
Thank you, Steve, for that very kind introduction. And I'm very proud to be part of the Pediatric Neuroscience Program, combination of efforts from Dell Medical School and Dell Children's Hospital. And I have wonderful colleagues, and Dr. Roach is on call, so he just had to leave. But thank you for inviting me, and I thank the meeting organizers, Dr. Friedman and Dr. Keith, for inviting me to be the keynote speaker. So I wanted to speak on two top subjects that are very scary to pediatricians, to ophthalmologists, maybe make them a little bit less scary and more understandable, and that is nystagmus and papilledema. I have one disclosure. It's not relevant to this talk. I have been a consultant for Sensei. So let's start with nystagmus. Nystagmus is a condition where the eyes move uncontrollably and often rapidly. We characterize it by the time of onset, either congenital or acquired, and I'll address both. Congenital It isn't present at the time of birth. It usually appears, congenital nystagmus, it usually appears between 4 weeks and 4 months of age. Acquired is typically after that period, 4 to 6 months of age, often after 6 months of age, occurring really at any age. As ophthalmologists, we characterize it in several ways. The direction, which would be horizontal or vertical or a combination therein. It can have a rotary component. The amplitude, we characterize it by amplitude, which is the distance between the excursion, either a small amplitude, which would be a tiny little shake, or a larger amplitude, or a larger amplitude, which would be kind of a larger to and fro. Also by the frequency, which means the speed, and associated or dissociated. And what really that means is it symmetric between the two eyes? There's a particular type of nystagmus, which I'll show you in a little bit of video, that is always worse in one eye compared to the other. And there can be nystagmus only in certain gaze positions, not in straight ahead gaze, but only in end gaze or side gaze. That's much more common and typically more benign. The anti-seizure drugs cause that. Any child that's had any cerebellar, any intervention of the cerebellum or condition of the cerebellum, they often have end gaze nystagmus. And accompanying nystagmus, the vision or visual attention. We can't get visual acuity in a baby, but visual attention, vision is often abnormal within varying degrees. So there's fear and reality with congenital onset nystagmus. The fear is that it's secondary to a brain tumor or it's secondary to opsoclonus myoclonus syndrome, and we need to refer this child to the emergency room stat. But in reality, the etiology may be very obvious to the ophthalmologist. It is visually significant cataracts. It's bilateral optic nerve hypoplasia. It's trashed retina from retinopathy of prematurity. It is very rarely congenital onset nystagmus, very rarely secondary to a brain tumor or oculomotor opsoclonus myoclonus syndrome. The etiology is typically something wrong with the retina or something wrong with the optic nerve. So there's a great paper that came out of Iowa where I did my fellowship that looked at the causes of congenital nystagmus that were referred into the pediatric ophthalmology practice. And these were typically patients that couldn't be diagnosed by their pediatric ophthalmologist or their ophthalmologist. These were not obvious causes of congenital onset nystagmus. And the breakdown is as follows. Albinism or inherited retinal dystrophy accounted for 46%. Albinism is on the leaderboard. Most often in the albinism category, it's oculocutaneous, which means involving the eye and skin, and much less often just the eye, ocular albinism. The second most common within that category, labor congenital amaurosis. I'll talk about that in a little bit. And then all the other retinal dystrophies, non-labor congenital amaurosis retinal dystrophies was in equal percentage. And I'll get into those in a moment. Anatomic retinal disorders like ROP, very obvious typically, but 10%. Congenital motor nystagmus was 10%. What that is a congenital onset of nystagmus. The vision is typically very good. It can be inherited. That was 10%. And that in congenital motor nystagmus, there's nothing wrong with the retina, nothing wrong with the optic nerve, and nothing wrong with the brain. The eyes just shake. Brain-based or neurologic was 7%. PVL causes a small amplitude nystagmus, so preemies. And optic nerve disorders, 6%. Atrophy or optic nerve hypoplasia. Often patients that have obvious, that patients were not referred in to this practice when they had obvious optic nerve problems. These were patients referred in because the etiology was unknown. Or could not be easily determined by the provider. 202 charts were reviewed in this study, and a brain MRI was obtained in 74 out of the 202. And 46 of those 74 The MRI was ordered because of the nystagmus and additional neuro or systemic findings, which were not greatly detailed in the paper. Only 14 of those 46 had an abnormal MRI. 9 had optic nerve hypoplasia. Like Demorcier's septo-optic dysplasia, we always order an MRI in those conditions because of midline brain abnormalities, pituitary axis abnormalities. 2 was Joubert syndrome. Joubert has a very distinctive seesaw nystagmus. Babies are hypotonic. They hypoventilate at birth. So MRI should be obtained in patients with Joubert, findings of Joubert, which would be a very distinctive nystagmus often, and those other neurologic signs. But what about the patients that had nystagmus only, that had no neuro findings? 28 in that pile of 74 that got a brain MRI had just nystagmus, no neuro findings. All 28 had normal brain MRIs. So, in summary, 81% of those who received an MRI, the MRI was normal. Only 19% had abnormal MRIs, and they were optic nerve hypoplasia, septo-optic dysplasia related, or Joubert related brain abnormalities noted, and not a single brain tumor. So the bottom line is, brain MRI is a very low yield in congenital onset nystagmus, especially if there's no neurologic signs or symptoms. And in total, 76% of cases of congenital onset in this paper were due to retinal pathology, namely albinism and other inherited retinal diseases. So here we have a baby with congenital onset nystagmus, and you can see that it is pretty chaotic appearing. There's a vertical component right now. It's of low amplitude, high frequency. There's a horizontal component. Her vision is poor. She has a lot of light sensitivity. She happened to have achromatopsia, and I'll get into these inherited retinal diseases in a moment. But over time, her nystagmus became very average-looking, horizontal, smaller amplitude, much less chaotic, with 6 months more age. So let's talk about the retinal causes of nystagmus. And the leading one, especially in my practice, this resonates completely in my practice, is oculocutaneous albinism. We need to, those features need to be present before we can make that diagnosis. We can make that diagnosis by targeted genetic testing, but it's often just made clinically. We've been doing this for a million years. So iris transillumination, I wanted to show you that. So the blue irides, that's a normal iris. But if you shine the light with our microscope called a slit lamp, so obviously you have to be an older child to possibly get this diagnosis. You put your chin in the rest of the slit lamp, which is our microscope, you skinny up the beam, and you shine it through the pupil to cause the red reflex. And the light comes back through the pupil and back through these little slits in the iris, which are transillumination defects. A normal iris should have no holes in it. These tiny little holes are only detected by this retroillumination, causing a red reflex, and the light comes back through these little holes. This is absolutely classic for oculocutaneous albinism. The photo at the bottom left is an OCA1. This is the no pigment patient. The light pours through the iris. There is almost no pigment in the iris. Very easy to transilluminate those patients, even early age. It is the latter 3 types of albinism, the less marked albinism, a bit more pigment. They have these smaller transillumination defects that can be harder to detect. They also have foveal hypoplasia, so that's another integral piece of the diagnosis, and that's why they don't have normal vision. The decreased visual acuity because of the lack of melanin at the behind the retina leads to the foveal underdevelopment, and the fovea is what gives us our 20/20 vision. The foveal lack of development leads to decreased visual acuity, which leads to the nystagmus. and that cross-section of the retina is performed with an ocular coherence tomographer. It is a non-invasive test that uses light rays to look at the very fine cross-sectional detail of the retina. And the fovea is underdeveloped, but we don't need to use that technology to make that diagnosis because that also requires cooperation, which we don't get out of babies. When we're looking at the back of the eye, the fovea has a particular light reflex. There's a mound of the retina that's thick at the very back of the eye in the fovea. And as we shine the light in there with our indirects, it has a particular appearance, and it's missing in children with albinism, all patients with albinism. What about ocular albinism? The skin pigment is normal. This can be very difficult to diagnose, but it's very rare. Ocular albinism is X-linked, and oculocutaneous albinism, all forms are autosomal recessive. So what about the other inherited retinal dystrophies? They're going by this acronym of IRD. Remember from medical school what comprises the photoreceptors within your retina. They're cones. They give our color vision. They occupy the center part of our retina, and they give us our 20/20 vision. The rods are at the periphery of the retina. They give us our night vision, black and white vision. They don't have color. They're not our color cones. And they mainly occupy the peripheral retina. So the rod-based dystrophies, everyone's heard about retinitis pigmentosa, but it doesn't present at birth. It affects the peripheral retina, not the center part of the retina, and it never leads to nystagmus at birth. So that's not one of the main causes of an inherited retinal dystrophy. That presents at birth with nystagmus. What are the top three? Labor congenital amaurosis. These babies are blind. It presents at birth with a chaotic nystagmus and poorly reactive pupils and very poor visual acuity with a very poor prognosis. 22 mutations cause labor congenital amaurosis, and we have one FDA-approved gene therapy for inherited retinal dystrophy, and that is one mutation for labor congenital amaurosis, RPE65. Other causes are achromatopsia. There are two main gene defects that cause achromatopsia. So that's the cones don't have color. The cones are malformed within the center of the retina. And then congenital stationary night blindness. These are the top three that would cause congenital onset nystagmus from an inherited retinal dystrophy. And in the exam, what we find is nystagmus, decreased vision, and the retina looks totally normal. So we make this diagnosis. We used to try to make this diagnosis of inherited retinal dystrophy by using ERG or electroretinograms, that's an EEG of the retina. Very hard to obtain. There's maybe two places in Texas you can get an ERG on an infant because they need to be sedated, et cetera. We're now just going to targeted gene testing, which is much better than looking at these squiggly lines and trying to determine the etiology of the inherited retinal dystrophy. So the retina looks normal, and the best clue to making this diagnosis, you can make it in the clinic, I can make it in the clinic, is light sensitivity, called hemerolopia. These children often have extreme photophobia right from birth. They cannot open their eyes outside. They have to have sunglasses or a hat. That's the best way for me to make a diagnosis of baby with nystagmus, poor vision, and light sensitivity. Retina looks normal, optic nerve looks normal. It's got to be inherited retinal dystrophy. So what are the optic nerve causes of congenital nystagmus? That's the other bucket of high-frequency etiologies of congenital nystagmus. Optic atrophy, which is death of a normal-sized optic nerve, and that is often from a brain-based disorder. Periventricular leukomalacia, primary hydrocephalus, congenital brain malformations, and some neurodevelopmental disorders. So you can see the top photo is, middle photo is a normal optic nerve. It is pink. You can see the size there. It has a little cup, which is the divot in the center. And the top photo is optic atrophy, so a normal-sized optic nerve, but it is pale, which implies death of the axons. What about optic nerve hypoplasia? So that is a small optic nerve. Our optic nerves are supposed to contain 1 million axons. It's anything less than 1 million, so it could be 10% off or 90% off. That's optic nerve hypoplasia. It's just a descriptive. It's a descriptive term. It does not indicate a cause or a syndrome. The optic nerve hypoplasia, that nerve is often pale, and even atrophic optic nerves will shrink. So let's talk a bit about septo-optic dysplasia. It goes by a bunch of names, septo-optic dysplasia or de Morsier syndrome. So the optic nerve hypoplasia in this syndrome, the optic nerve is small either unilaterally or bilaterally. There's pituitary axis abnormalities, as I indicated. That's frequent, and we often see an ectopic pituitary bright spot on MRI. Pituitary hormone deficiencies, hypothalamic dysfunctions, which consist of abnormal eating, either excessive eating or too little appetite. Sleep dysregulation is very common in these patients, as well as autism spectrum disorder. Oh, let's go back. So the optic nerve on the bottom, there's a little dotted line around what the normal size optic nerve should look like. And we see a very tiny optic nerve within that dotted area that is the normal size. We see a very small optic nerve there. That's an obvious diagnosis, but optic nerve hypoplasia is not necessarily that obvious. So let's go back to summarize on congenital nystagmus, the fear and the reality, the fear that it's secondary to brain tumor, or fear that it's opsoclonus myoclonus syndrome. You have to refer to the ER stat, that's a fear. The reality is it is rarely secondary, not intracranial pathology, it should state brain tumor. Very rarely secondary to a brain tumor or opsoclonus myoclonus syndrome. And fine, if you have a baby that has primary hydrocephalus and a huge HFOC, okay, we're going to send that child to the ER. But mainly there's no brain tumor and no opsoclonus myoclonus syndrome. The etiology is typically albinism or other inherited retinal disease or optic nerve hypoplasia or optic atrophy. So instead of going straight to the ER, refer to a pediatric ophthalmologist or pediatric neuro-ophthalmologist, and we will orchestrate the workup. So if I have a patient that I suspect, based on that constellation of findings, a nystagmus, poor vision, possibly poorly reactive pupils, and a lot of light sensitivity, it's going to be I'm going to go to targeted genetic testing. If there's an optic nerve abnormality, we have to get an MRI. I mean, we have to rule out a compressive cause because congenital brain tumors can cause optic atrophy. Super rare, but I've seen probably between my experience, 16, 17 years as a pediatric neuro-ophthalmologist, maybe 10 congenital brain tumors. So we're going to get an MRI, and we're obviously the septo-optic dysplasia patients, we're going to get an MRI, and then possible genetic testing. So what about the parental fear? There's a lot of fear in the parents that the nystagmus in this baby will never go away. They are never going to see. Their vision is terrible at birth. But the reality is congenital nystagmus, 95% is going to improve and quiet down, and their vision is going to start to develop. That quieting of the amplitude and the multivectoral nature improves in the first 1 to 2 to 3 years of life. Like I said, the amplitude decreases, and even the nystagmus may disappear. OCA1, oculocutaneous albinism 1, where there's no pigment, labor congenital amaurosis, where these children have a completely trashed retina, that nystagmus doesn't go away. But many of the other causes of nystagmus will. So typically the vision improves in that time frame as well, and the ultimate vision may be mild vision impairment or severe vision impairment depending on the etiology. So let's talk about acquired nystagmus. Fear equals reality. Acquired nystagmus is bad. High suspicion for dangerous intracranial pathology. So that is a reason to send to us urgently. to pediatric ophthalmology or pediatric neuro-ophthalmology. So this is a child I met, let's see, I'll try to start the video, a long time ago. She's probably 20 now. And at the age of 3, she had this onset of nystagmus. She was a normal child and, without nystagmus until this time. I'll play it again. It's a dissociated. One eye's nystagmus is a little bit more pronounced than the other. It's high frequency, small amplitude, very shimmery nystagmus, and varies in its frequency with time in these moments that we watched her. She had a non-NF1 hypothalamic chiasmatic glioma. She was sent to the ER. She had optic atrophy and poor visual acuity. So fear equals reality when we have acquired nystagmus. Let's move on to papilledema, fear and reality. Fear is, you're going to see this papilledema in quotes. Papilledema is secondary to a brain tumor. There's a high risk of death and blindness, and that needs to be referred to the emergency room stat. But the reality is, slightly full optic nerves, anomalously full optic nerves are often diagnosed as, quote, papilledema. It is a common mistake made by the people we train, ophthalmologists, pediatric ophthalmologists, and optometrists. So these are going to be in your practice, that this optometrist saw this child and has papilledema, but it may not be papilledema. So what is papilledema? Every full optic nerve is not papilledema. Papilledema is a swollen optic nerve, full optic nerve, due to elevated intracranial pressure. That's it. You have to have elevated intracranial pressure. But what would be the other causes of a full, abnormal appearing optic nerve? Optic neuritis rarely, but mainly buried disc, optic disc drusen. And I'm going to get into all these things right now. So in papilledema, that's a swollen optic nerve due to elevated intracranial pressure. Severe papilledema, and I'll show photos of this, it has a high likelihood of leading to optic nerve death, and those patients are going to lose vision. They may present with poor vision or develop it right when they're sitting in your chair, and it happens just like that. Mild to moderate papilledema, it does not lead to poor visual acuity. These kids and adults, but we're talking about pediatric patients, their visual acuity is totally normal. They may have some peripheral vision abnormalities, visual field defects that are only picked up on automated testing. Can't do that in a 3-year-old or a 5-year-old, which may or may not be reversible. But their visual acuity, visual attention is normal. What about the laterality? Typically it's bilateral. It could be a little bit asymmetric. Severity of papilledema. There's 2 ways for us as ophthalmologists to characterize it. Dr. Friesen, thousands of years ago, created a grading system of 1 to 5. I don't typically use that. I just use mild, moderate, and severe. So here is the Friesen scale, courtesy of Moran Eye Institute, grade 1 and 2. You'll see in these photographs that only segments of the optic nerve are abnormally full. Like, we ought to see a nice sharp line around the border of the optic nerve. But you can see in the top 2 in the green circle that it's the superior and the nasal and the inferior border of the optic nerve that is full. But we see all the vessels. Grade 3, that's kind of in your moderate danger zone. All the entire border of the optic nerve is full, and we can't see some of the blood vessels because the swelling of the axons has covered up some of the vasculature. Grade 4 and 5, I mean, this is like a med student can diagnose this. These are really swollen optic nerves, and when you look in the eye, we see in 3 dimension, the bottom one looks like a champagne cork. There are infarcts and hemorrhages on the optic nerve, super obvious, pretty severe. So mild, moderate, and severe. So what are the causes of of papilledema? So there's 2 studies listed here, and I've given the frequency percentages of the etiologies based on these 2 papers, and they're color-coded. The leading cause is idiopathic intracranial hypertension. What is that? It depends on when you trained, or if you're an ophthalmologist, or a pediatric, or a pediatrician, or a neurologist as to what we call it. It's like crazy making how many names we have for this condition. Idiopathic intracranial hypertension came about maybe 20 years ago or 15 years ago. It replaced pseudotumor cerebri, which has primary and secondary. Now that's come back into vogue in ophthalmology. Talking to Steve Roach and my neurology colleagues here, often in the neurology literature, primary intracranial hypertension. So it's all the same thing. What do these patients look like? Well, overweight menstruating females in an adult practice, that is the absolute #1 cause of idiopathic intracranial hypertension. But in a pediatric practice, we have a lot of kids who don't fit that profile, and a lot of idiopathic intracranial hypertension that in prepubescent, not overweight boys. Boys equal girls. What can be the associated risk factor is steroid withdrawal, steroid use, endocrinopathy such as low thyroid or low growth hormone, tetracycline-related medications, vitamin A use, Accutane, and a lot of unknown. And you can see the percentage, 87 to 42%, depending on which of these studies you look at. Intracranial tumor, 16% in both, so pretty small, but a significant, obviously, we're going to get an MRI when we see papilledema. Craniosynostosis, in one study, 18%, primary hydrocephalus, small, and cerebral venous thrombosis. Sinus thrombosis also causes elevated intracranial pressure and papilledema. So optic neuritis is an inflammation or infection of the optic nerve. It also causes a full and swollen optic nerve, but it is not secondary to elevated intracranial pressure. Does it get referred to me as papilledema? It's so infrequent that it may get referred to me as papilledema, but I don't think it fakes out many providers in the eye space because the visual acuity is rotten. Very decreased visual acuity in all forms of optic neuritis, and it's often unilateral, unlike papilledema. What are the causes? The demyelinating diseases all clumped together here, multiple sclerosis, myelin, oligodendrocyte, glycoprotein antibody disease. I had to look that up because it goes by MOG so frequently, but I've forgotten what the acronym meant. Neuromyelitis optica spectrum disorders, and ADEM, acute disseminated encephalomyelitis. These are all clumped into this autoimmune optic neuropathies and clinically isolated syndrome. Also, vaccinations. An inflammatory response to the optic nerve after a virus or a vaccination also causes optic neuritis and vision loss. Cat scratch disease, sarcoidosis. We don't see a lot of Lyme disease, and that can be medication-induced. I took care of some patients with chloramphenicol, optic nerve toxicity. So here are some photos. On the left are optic nerve fullness, swelling, which is due to multiple sclerosis, optic neuritis related to MS. And in this demyelinating category, what we see on MRI is often the entire optic nerve lights up with enhances. So helps us make the diagnosis: pain on movement, acute loss of visual acuity. Cat scratch, Bartonella-related optic neuropathy. We often see this exudate in the center of the retina called a macular star. Post-viral optic neuritis can have a little optic nerve swelling as well. You can see these things all look very similar. Sarcoidosis, I don't think I've ever seen a child with sarcoidosis. I've seen some adults in my fellowship. There's a nodule on the top of the optic nerve often that shows the inflammation. What about the great mimicker that I see, I would say every week or every other week? Buried optic disc drusen. which is the giant mimicker of papilledema, and it has exploded. So I have been a pediatric ophthalmologist for 33 years, and I did a second fellowship, 2005, however many years ago that was. We never got referred patients with fake-out pseudopapilledema then. But the explosion in the use of retinal photography in, I believe, optometric offices find this condition, and it gets diagnosed as papilledema. It goes down this cycle of getting an MRI when it's actually buried disc drusen. So look at these two optic nerves. One has papilledema, and one is buried disc drusen. So let me tell you about what optic disc drusen are. They occur maybe in 4% of the population. They are nodules of acellular debris, which are secondary to slowed axoplasmic flow. They exclusively occur in small optic nerve heads. Who's got a small optic nerve head? A black ancestry, large optic nerves. Almost never do we see optic disc drusen. It's as if that axoplasmic flow has plenty of room. There's a big scleral opening at the back of the eye that the optic nerve can go through, and all that axoplasmic debris gets flushed out. But whites and Asians, small optic nerves with no cup, like it's getting choked. There is a smaller scleral canal in which those million optic nerves that comprise the, a million axons of which comprise the optic nerve have to get back through to the brain. So small optic nerve heads are more common in whites and Asians, next is Hispanic, and almost never in those with black ancestry. What is the life cycle? There is a life cycle to drusen. They start buried, and then they may become superficial, or stay buried an entire life. They start in childhood. These are buried drusen are those nodules, but they're underneath the border of the optic nerve. They develop and evolve in the first 2 decades of life, and they're typically not calcified at that time. And it looks like papilledema, hence the term in our literature of pseudopapilledema. So over time, after the 2nd decade, into the 3rd decade and beyond, they pop out onto the top of the optic nerve head, usually calcifying. Super obvious diagnosis. The bottom photograph, you can see this crystalline nodules on the top of the optic nerve head. No one's faked out. That's not papilledema. Everyone knows that's, everyone in the eye space, we all know what that is. It's when they're buried that it looks like papilledema. And that happens to be in children. So how do we distinguish between drusen and papilledema? Well, we shouldn't rush to MRI and LP with opening pressure. What I do is I ask about headache. Headache is very common in elevated intracranial pressure. I ask about risk factors for idiopathic intracranial hypertension. And I do the following tests, as many as I can based on the patient's cooperation. Optic nerve head appearance, I'll take optic nerve photos. Papilledema waxes and wanes. Optic disc drusen don't really evolve. The appearance of the fullness of the optic nerve is not going to change in serial visits in a year. Ocular coherence tomography, these are the light rays, a non-invasive test that uses light rays to take these very fine cross sections through the back of the eye, and we measure the nerve fiber layer thickness around the optic nerve. If it's super thick, if it's over 140 microns, I'm worried it's papilledema. Less than 140, not so worried, especially if there's no symptoms or risk factors. We also use some other testing to look for drusen. Another OCT, ocular coherence tomography test called enhanced depth imaging to look for those nodules. Drusen, if they're superficial enough, they glow in the dark. See the they autofluoresce, and you see that in that top left photo. That's a very easy test to obtain, and we have all that equipment here at Dell Children's in the pavilion. Also, bowing of the back of the eye on the OCT images also is suggestive of, so several tests that we can use to diagnose between buried disc drusen and papilledema. The last test is an ultrasound of the back of the eye. That's what was the go-to when that's how I was educated, back when dinosaurs roamed the earth, was to look for calcium. But drusen are not calcified in children. They are in adults. So back to the fear and reality in papilledema. The fear is that it's real papilledema, and it's secondary to brain tumor. Yeah, real papilledema, I am worried about that. And I would refer that. But in reality, not every full optic nerve is papilledema, but they often get diagnosed as papilledema. True papilledema, the most common etiology, is idiopathic intracranial hypertension. Vision is usually normal until the very late stages and severity. Other causes of, quote, papilledema, optic neuritis, much less common. Always acute vision loss and typically unilateral. Buried dystros in my practice exploded. There's no vision loss. That optic nerve is only mildly full on the borders, and it can be challenging to distinguish, but what we try to do is avoid the MRI and LP. There's my references, and I'm done. I have forgotten how much time was given, if there's any time for Q&A. There is? Okay. Oh, you have those signs up. Yes, ma'am.
So I have 4 questions. I'm a general pediatrician. So the first one is, when a baby is born with lighter eye color, parents are like super happy.
And then it darkens.
And the first question they're asking us, not even when it darkens, at the first newborn visit, are they going to have this lifelong?
No.
What's the correct? Yeah, and what's the correct answer is?
No, they'll become more pigmented, and the real color will probably be revealed at about a year.
Okay, yeah, that's what I've been telling them. I just wanted to find out.
Okay.
The second question was, if we see a patient with acquired nystagmus, and now we have this 24 to 48-hour line, we'll of course be happy to call you if you have a direct number where somebody will actually answer. Dr. Roach got on the phone with me day before for a head injury. But anyway, so how would you like us to present the patient, considering that we have 60 seconds, you have 30 seconds to listen to us, and the parent is probably in the room? So if you can tell me some quick, what do you say?
So because of my chair role, I'm only in clinic 1 day a week and a half day a week in the operating room. So I am not the best go-to, but my wonderful partners at Dell Children's Eye Clinic, somebody's always on call. And they will help navigate seeing the patient maybe that day or meeting the patient in the emergency room.
And the third question is the steroid withdrawal that you mentioned.
Mm-hmm.
So, like it or not, we have to prescribe steroids every single day, more for some patients than for others. And there's so much for steroid phobia. I don't want to ever be in a situation months or years later, or by the time the patient's 21, where the parent's going to say, I told you so, don't use the steroid, and you still used it. So what are the criteria on what will not cause a steroid withdrawal and what will?
I have no idea. But I do know that elevated idiopathic intracranial hypertension, the leading symptom is headache. So if you've got headache that develops in the time of your withdrawal, in little children, they may not complain of headache, but there's lethargy, head banging, head rubbing. A verbal child will typically complain of headache, and the headache is particular characteristics of the headache that are worrisome, because headache is super common, right? We have headache from allergies, there's stress, there's a lot of reasons for headache, migraine. The headache from elevated intracranial pressure often occurs in the middle of the night or on awakening, because at night our CO2 goes up and there's vascular dilatation and it makes the headache worse. Headache throughout the day, of course, headache that's worse with moving around, jumping on a trampoline, activity. That's also suggestive of elevated intracranial pressure. So I would say on your steroid withdrawal, you get headache, that's worrisome.
And a sub-question to that would be, is it reversible at that stage?
Yes. So idiopathic intracranial hypertension. So if I get a patient that's undergone the steroid withdrawal, now has headache and It's typically not that 4+ severe swelling. It's usually like two moderate swelling or a mild. I will put the patient on, gets an MRI and then gets an LP. I'll place the patient on Diamox according to their weight, and I'll leave them on that for 6 months. I start at a higher dose, near the maximum dose, and then I start to taper. And often their optic nerves are fine, very minimal damage based on based on the OCT, nerve fiber layer dropout, or none. These kids' optic nerves are super healthy, and they can recover to absolutely normal as I get the papilledema under control, and then I start to taper off the Diamox at month 6, and we often successfully get off.
And my last question, because it's not really your territory, but since you had the word craniosynostosis there.
Oh, that is my territory.
Oh, okay. And, all ears with neurology right now. So I had one infant, her anterior fontanelle closed before 6 months of age, which of course to me was completely abnormal.
Right.
She saw craniofacial, they said it's totally normal. The mother's going crazy because the referring physician is saying this is abnormal. The specialist is telling her this is normal. Finally, the neurosurgeon called me and we had a conversation. But now the infant's like more than 1 year, but the mother's stuck with the feeling anything happens to the child, she goes back to that. Like you said, it was abnormal, and the neurosurgeon saying, and anything, it could be related to the toes, but mom will still attribute it to the
closed fontanelle.
Closing. Just any comments? You don't have to, but you could.
Yeah, that's worrisome. A closed fontanelle at a very young age makes it sound like a craniosynostosis, but even if it was a very, the metopic suture closes at 9 months of age, and the sagittal suture, the rest of the calvarial sutures can close like in the 2nd decade of life. There could be a small amount of sagittal suture synostosis, not encompassing the entire sagittal suture, but that little bit of sagittal suture synostosis may or may not be related to elevated intracranial pressure, isolated, but it's not going to be causing probably all the other symptoms and signs and worries of that parent. But isolated suture closure, 6 to 20% can develop elevated intracranial pressure in the first decade of life. Sagittal suture synostosis is the most common. Isolated sagittal suture synostosis most common to have elevated intracranial pressure. Coronal suture synostosis, unilateral. Typically, it would be unilateral if it's not if it's isolated. That can also, but lesser percentage of patients. And these are old papers. In my experience, and I have taken care of a ton of patients with congenital craniosynostosis, and it's basically mainly from my experience at CHOP, Children's Hospital of Philadelphia. I was on a craniofacial team for 7 years. It was a fabulous experience, and I've carried through that interest in these patients and knowledge base since then. I can count on maybe 3 patients with isolated non-syndromic craniosynostosis that had papilledema. Super rare. I think those papers are overstating the percentage of patients that have papilledema, elevated intracranial pressure with isolated non-syndromic craniosynostosis. I hope I answered that okay.
Thank you very, very much. More than 5 times over.
Okay.
Thanks.
I think I'm probably, out of time, right? Yes. Okay. Thank you so much.